Okay. Hi, everyone. Thanks for joining our meeting today. This is something new that we've just started at the clinic. It's called Sugar Hour, and some of you guys have, met me before when I did Sugar Club before the pandemic happened, just in the waiting room at our clinic. But now we're having these sessions once a month. Right now, we have two more meetings set up, but we're open to having even more with a lot of topics to cover today. So we've decided to focus on resources and just general recommendations for today. I'm joined here with Adam, Matthew, Aditi, Ted, Nerme, Jessica, and also Bo, who is our certified diabetes educator here at our clinic, who comes in around once a month. And some of you guys may have already met her. So thank you so much, Bo, for joining us today.
No problem. I'm glad to be here.
Okay, and hopefully Dr. Kernew is able to join us a little later on. But given the time, we have an hour today, so we're just gonna get started. Move on. So today we'll be talking about Diabetes Canada website and then the glycemic index. And we'll also be covering a bit about diabetic foot care, eye disease, and the screening resources that come along with that. Very briefly through types of insulin, and then we'll end it off with covering the SMART goals.
Right, so I'll be covering just very briefly navigation of the Diabetes Canada website. So a lot of the topics that we're going to be covering upon today, there's a lot of useful resources on this website. So on the next slide here, you have just a really brief screenshot of the Diabetes Canada website and what you'll see when you first get on it. So basically here we have highlighted sort of two different areas. You have the sidebar on the left, which is highlighted by the orange square, and then you have these sort of buttons on that's highlighted by the red square. Both sort of take you to the same information or same parts of the website, but we found that sort of the sidebar on the left that's highlighted by the orange rectangle to be more specific and easier to navigate. So we'll be touching upon that. So on the next slide, we have one part of the sidebar, which is the type 2 risks. And here you can sort of learn more about sort of the risks of diabetes, some symptoms, and also a useful test towards gauging whether or not someone may be at risk of developing pre-diabetes or diabetes. So on the next slide is just like a brief resource that you can find through Diabetes Canada, which is an assessment of your risk. So next, the next slide. Next slide on the Diabetes Canada website, there's a section on a whole bunch of resources regarding lifestyle and living with diabetes. And I know that later on we'll cover more about some sort of exercising, the glycemic index, and those type of resources and strategies towards sort of managing that can be found in this section of the website. On to the next slide. There's also some resources similar to what we're presenting here today on the diabetes website as well. So there's webinars that you can access, and basically these will be videos that are created by professionals regarding issues or sort of tips of dealing with sort of the challenges that come with diabetes. And also there is Q&A of sort of diabetic patients and what sort of experts would recommend and them answering their questions. And then a final section to the diabetes websites is under sort of healthcare providers and patient resources. And once you click on sort of this section of the website, it will bring you to sort of a catalog of different resources. So on the next slide, we have a photo of where sort of this will take you. And in this web page, there will be a lot of sort of links to resources that you can use to help sort of achieve the goals and sort of address the issues that we'll be covering on today. So for example, here, there's a goal calendar sort of a tool that you could use to help with dealing with some issues that come with diabetes.
Okay, and so right now I'll be kind of taking over a bit, and I'll be talking a little bit more about healthy eating and the glycemic index. And so on the next slide, we'll kind of answer kind of like one of the most important questions that I think, and the most important question when it comes to diabetes and healthy eating is, what does healthy eating really mean for me? And I think this is the most important question because, whenever you go to the doctors, they're going to tell you to, lose weight, eat healthier, eat healthier, eat healthier. But like, what does that really mean? And so that's kind of what I want to answer with this section. And I'll kind of be taking you through like what it really means to eat healthy. So the first question I want to answer is, why should we eat healthy? And one of the most obvious reasons, which I kind of gave away, is because losing weight is one of the best things you can do for putting your diabetes into remission. And so you see a little graph here. Basically, this graph was taken from a trial they did called the DIRECT trial. And what they learned from this trial was if you lost 15 or more kilograms in the first 7 years after your onset of diabetes, the chance of you to kind of put your diabetes into remission was 86%. So 86% of the people that lost more than 15 kilos were able to get rid of their diabetes effectively. And you can see the stats are a little lower for losing less weight. So if you lost less than 5 kilos, you had a 7% chance. If you lost between 5 and 10 kilos, it was a 34% chance. And between 10 to 15 kilos, it was a 57% chance. And you can still see that's still a significant amount of people. So that's almost 1 in 2 people with diabetes that were put into remission just by losing 10 kilos, 10 to 15 kilos. And so the age-old question of, how do I eat healthy? What diet works for me? And things like that. Those are very important and very good questions to have. And one thing I would recommend you do is you go to Dr. Kernier's YouTube channel and you kind of just search the types of diet that you're interested in, because we most likely have a video on it. We've got videos on things like the keto diet, on plant-based eating, on soups and smoothies. And so I would definitely recommend that you take a look and try to find something that really works for you. On the next slide, we're just going to take a look and we're going to see.
Over here. So just pause for a second. So this is something actually really important. This is, to me, brand new information, in the sense is that I always think of diabetes as being irreversible. You're stuck with it. But this tells me that if you're overweight and losing about 20 to 30 pounds, I'll repeat that. If you're overweight, losing 20 to 30 pounds, you can actually slow down the progression of diabetes, allowing some healing to take place. Because once you make the diagnosis of diabetes with a hemoglobin A1C of 6.5% or greater, it usually means that half the cells that make insulin are dead, and the rest are working overtime. So this is actually great information to say that you can do something about the insulin resistance, and maybe you can regenerate some of your pancreatic cells. This is type 2 diabetes we're talking about, and this is talking people who have diabetes for less than 5 years, and these are people that are really working hard at this. In fact, the next webinar, the one that is on March the 17th, will be how to put your diabetes into remission. So to me, this is wonderful. What COVID and other infections has taught me is that many of us have lost years of life, and many of us have, lost our resilience. And to me, getting this back and finding a way to actually lose weight, to become healthier, makes you live longer, makes you feel better, and especially if you have diabetes. So this is actually phenomenal. Keep showing us some more caveats here. Thank you so much. And also, if anybody has any questions, just throw your 2 cents in. I want to hear from everybody. Is Bo there in the background?
I'm here. I forgot I was muted.
So remember, Bo is fantastic. She's a kind, gentle soul. I'm the pain in the neck guy. But basically, Bo and I have been around for a long time, and I would have never said that that you could put diabetes into remission. I use the word remission. You can't cure it, but you can put into remission. But that and for many of us is this transformation of diet and lifestyle changes. Now there's different diets, but to be honest with you, the best diet to put diabetes into remission is that you gotta eat less calories, you gotta exercise, and you have to eat more plants and eat less and lots of fiber. Anything else you want to add to that, Bo?
Well, I can tell you that I saw a patient today that lost 75 pounds and came off most of her medications. She came off insulin.
Yeah, and so you can see that insulin is usually a medication we use at the end stage of diabetes. So, this is phenomenal. But if you keep doing your old-fashioned ways that got you to diabetes, it's going to get worse. So, fantastic. Let's keep moving. Great. Any thoughts from anybody? I know it's hard, but it's actually doable. I can do it. You can do it. Go ahead. Keep going. I want to hear the next slide. Get the next slide there.
Perfect. Yeah. So one of the things that we also want to do is we want to eat foods that won't cause a blood pressure spike or a blood sugar spike. Sorry. And when the way we can do this is basically it starts from the planning phase. So when you're going to the grocery store to buy foods, you want to ensure that the foods you pick are not carbohydrate heavy foods. As Dr. Kearney was just saying, plants and vegetables are great. You also want to pick foods that are higher in fiber, which are going to make you feel full for longer. And that's going to hopefully try to curb some of that midnight snacking, some of those extra snacks throughout the days, And then we want to supplement our meals with things like vegetables and lean proteins. And I say these two things because A, they are more likely to have lower carbohydrates, and B, they can also help you feel full. And then one other thing we want to do is we want to look at something called the glycemic index, and we also then want to look at something called the glycemic load. And so on the next slide, I'll kind of introduce what the glycemic index is. It's actually a resource that Diabetes Canada provides. And I know it looks really complicated, but just remember, green is good, yellow is okay, and red is bad. And if you remember that, then you're great to use this resource. This resource basically tells you what kind of foods are better for me to eat, what kind of foods are worse for me to eat, and what kind of foods are okay. So an example I see over here is in the grains section. White bread is something that has a very high glycemic index. This means that as soon as you kind of eat that white bread, it's going to basically turn into sugar in your blood very, very fast. Whereas if you were to get something like sourdough bread or heavy mixed grain bread, that's going to take a lot longer for it, for your body to digest and for it to break down those sugars and release it to your bloodstream. And so that's a little better as an alternative than the white bread. Of course, the best solution here would to kind of cut out bread and focus a lot more on lean meats and on vegetables, but that's a small change that you can do. And so I would recommend for you to kind of use what kind of TED taught us and go to the glycemic index chart on the Diabetes Canada website and see if you can maybe print this out for yourself or kind of take note of it before you go grocery shopping next. Alrighty. And so I think I'm going to hand it off to Ginny over here.
Yep. So this is a short little quiz. So which is watermelon high or low on the glycemic index? Take your best guess. You can write it in the chat and feel free to unmute yourself and just say the answer out loud as well. Mm-hmm. Okay. Oh, can everyone hear me?
Yep.
Oh, okay. You can try leaving and re-entering the meeting if you're unable to hear me. And I think Bo already gave away the answer here in the chat. So watermelon is high on
Was
the
I too fast?
I think no, it's good. So it is high, and I think Nurmi sort of mentioned earlier that there's a difference between the glycemic index and glycemic load. Nurmi, did you want to talk a little bit about that?
Yeah, for sure. So we kind of talked a little bit about glycemic index and how to find the glycemic index chart. One thing to kind of be a little wary about is that the glycemic index doesn't always give you the full picture. Often what happens is the glycemic index gives you part of the picture, and the glycemic load also gives you another part of the picture. And so you might be wondering, okay, I hear the word glycemic a lot. What does this really mean? Basically, you can think of it as the amount of carbohydrates per serving. So even though watermelon has a very high glycemic index, it will have a low glycemic load because you're probably not going to be eating one entire watermelon in one sitting. Rather, you'd probably break it up into smaller pieces and then have a piece at a time, right? And so one thing that you want to be kind of worried about is when you're looking at the glycemic index, you want to make sure that you know that it's for the entire product itself or for some set amount, and it's not going to be kind of representative of what you might eat in one sitting or in one serving. So that's just something that you want to be wary about when you're looking at the glycemic index and the glycemic load.
Mm-hmm. Yeah, so watermelon, although it is high on the glycemic index, serving of watermelon has such little carbohydrates that's actually only a 5 on the glycemic load, which is low.
So it's a good food.
The next question is something that I think Dr. Kern already knows the answer to. So does orange juice or apple juice contain more sugar?
Does actually Coke have more sugar than this or not? So, well, you know what? Turns out that apple juice has more sugar than any juice, and it has more sugar than Coke. And so basically liquid calories are bad, right? Tell us about that, Ginny.
Mm-hmm. So this is based on the U.S. Department of Agriculture that got it off of their website. And I was actually a bit shocked myself that apple juice contains a lot of sugar. It's actually 9.6 grams of sugar per 100 milliliters, compared with orange juice, which has 8.4 grams of sugar per 100 milliliters. So don't drink your fruits. You'd rather just have the whole fruit that has the fibers and the proteins within it. So that's something that, especially if you have high sugar levels, this is something that you want to avoid. You don't want to be drinking any fruit juices.
So Bo, Bo's our diabetic educator, and so the only time when should you have juice?
Well, when you're treating a low blood sugar, Dr. Kernu, but I would also say, because you said I was the kind soul, so we do realize that people have a limited ability to make all kinds of changes. If people are really enjoying juice, what we would suggest is they have it with food, so that will slow down the digestion of the sugar, because they'll have the toast or whatever it is, to the solid food to kind of soak up some of that liquid sugar.
So it's kind of interesting is that my advice to everybody, especially if you have diabetes, you want to lose weight, the number one beverage is water. And having 2 glasses of water with every meal is health food. And if you're trying to lose weight, juices, sugar drinks make it so hard. And to me, having any juice right now is having a little bit of cocaine to your dopamine system. It really stimulates your appetite and things of that nature. And, while diet drinks have no calories, for many of us, they stimulate us to eat more. So be careful, learn your body a little bit more right now. So as Ginny said, you're better off to eat your fruit than drink your fruit. I think most of us are struggling, and this way is a easy fix. I call this a low-hanging fruit. If you're serious about your diabetes and you're serious about your weight, you want to really keep things like alcohol, because alcohol goes directly to sugar. And sugar goes directly to sugar, and the more simple. So you're absolutely right. So none of us are perfect, but that's something I'm really trying to take control of. Is that something just to think about? Sure. The only person who's perfect is my wife, and the rest is a bunch of schmucks, including myself. But I'm trying to be less of a schmuck as time goes on. So I'll encourage that. Absolutely.
All right. Good evening, everyone. So now we're just going to talk a little bit about diabetes and foot care. So we're going to start with, I guess, what foot ulcers are, because this is a very common complication of diabetes, and actually up to 25% of diabetes will suffer from a diabetic foot ulcer at least once in their lifetime. There's a lot of underlying causes of this, which include loss of sensation in your feet, poor blood flow and faulty veins, or prolonged pressure on your feet. A main cause is actually something called diabetic neuropathy, and you can see that in this top illustration up here. So you can see that diabetic neuropathy actually occurs in about up to 50% of diabetes patients, and this involves high blood sugar interfering with nerve signals, and this can also be attributed to the potential ability for high blood sugars to actually weaken the vessel walls, causing the blood flow to be lowered into that area and cause the nerves to become damaged or die. And what happens here is, because you're not able to feel, I guess, the damage on your feet, it can lead to you sustaining injuries that you don't even know about on your feet, and these can develop into an ulcer. It typically occurs in 4 different stages, with stage 1 being identifiable by reddening of skin over bony areas. Then stage 2, you can see blisters, peeling, thickened or cracked skin. Stage 3, that skin now becomes broken and can lead to a bloody drainage. And stage 4, which is where it actually breaks through the skin and can become so severe it can involve skin, muscle, tendon, and even bone in some cases. So in 2015, in terms of just putting this into perspective in Ontario, in 2015, about 16,600 to 27,600 Ontarians had a diabetic foot ulcer, and about 2,000 of them resulted in an amputation below the knee. And this is a pretty serious number. And in fact, one amputation every 4 hours in Ontario is attributed to a diabetic foot ulcer. So despite the daily benefits of foot inspections, so checking your feet for signs of an ulcer, about 75% of patients who were polled said that they spent less than 1 minute, or actually no time per day, checking their feet. So we're going to talk a little bit about some ways you can kind of include this in your daily routine. So these are just some of the recommendations from medical professionals on how to prevent diabetic foot ulcers from starting and progressing. So first, you're going to try to do daily foot inspections, looking for things like redness, swelling, warmth, blisters, or ingrown toenails. And a good tip is actually to use a mirror when you're doing this, because where it's more frequent that these ulcers are going to begin are on the soles of your feet, the heel of your foot, that kind of thing. And if you're not using a mirror and you can't see all the way at the bottom of your foot, one could be growing right under your nose and you wouldn't know about it. Another key thing that you should look for is getting shoes that fit properly. And you might be asking what I mean by this. We want to make sure they're not too tight, they're not too loose. And you also want to make sure that if you are buying shoes, try to do so in the afternoon or evening, when our feet tend to swell up a little bit more, just so that way you can be that much more sure that it'll be a good fit for you. When you're in the house, wear clean, dry socks and try to avoid tight elastics, and avoid walking barefoot, as I mentioned, so you don't sustain damage to your feet. Again, as Nirme mentioned, blood sugar and managing blood sugar, very important. Same with weight loss. And these can help by, again, reducing that diabetic neuropathy and also helping to alleviate some of that pressure on your feet. So Diabetes Canada has some great resources that can help simplify this pretty complicated topic. So as you can see up here, I have a screenshot of a do's and don'ts list that is published by Diabetes Canada that you can find on their website. And it really helps to kind of put everything into perspective on, what to do when you're buying shoes, how to check your feet properly. So be sure to check that out to make sure you're doing so correctly. Now, I just wanted to give you guys an opportunity to kind of brainstorm some ways that we can actually add foot care to our daily routine. So some ideas that I have include trying to give yourself a consistent time and stick to it every day, because that's how our habits can form properly. Also, try to do checks before when you're already checking your feet anyway. So for example, every morning before I put on socks, I'm, looking at my feet. So take an extra 1 or 2 minutes to just, pull out a mirror, maybe check the bottom of your feet, make sure you're not experiencing redness or any pain there, and that'll be good for your day. Or you can also set reminders for yourself, or print out a checklist and put it in a very visible place so you can be reminded throughout your day. So yeah, on the next slide here, you can see that I kind of created this sample foot chart. Obviously, you don't have to do it exactly like this, but this is just an indication of some things that you might want to add and consider when you're doing your foot check. So for example, I have a time up there, make sure I'm doing it every day when I wake up. Things to look for, so for example, redness, swelling, having there just so I can check off the boxes. And it also provides me some reminders and guidance for the rest of the day. So again, if you need any help setting up your own table, feel free to message us, and we'd be more than happy to help you consider creating these. And lastly, these are just some additional resources that might be helpful for you. So for the first one is a link to St. Joseph's Hospital Care for Your Feet, and there they have information sheets, interactive tools, community resources, things like healthy eating, and for example, a goal calendar that can help you really get on track of your foot care. There's also Feet First Foot Care Clinic, which is a Hamilton-based foot care clinic that was recently opened during the lockdown. And they can help you with your calluses, ingrown toenails, or diabetic foot care in general. Likewise, the Hamilton Family Health Team Foot Care Services and HNHB Healthline in-home foot care are good databases that provide a list of foot care services for diabetes, both in clinic and in home, if you aren't able to leave your house. And lastly, I wanted to point out the Mayor's Institute Wound Care Clinic, also in Hamilton. We've attached the phone number there, and they specialize in wound care treatment, especially diabetes, prevention, as well as education. So make sure you call for an appointment, and if you need a referral, please talk to Dr. Kernew, and he can write you a referral as necessary. And most fees are actually covered through OHIP, so that's a plus there.
Matthew, it's Bo. Can I just add a couple of points?
For sure.
So, I know you had it on your slide, but smoking, when you were talking about neuropathy and the risk of amputations, and it's the impact on the nerves related to the high sugars, but it's also about circulation, and smoking plays a huge role. So if people can work on tackling that behavior change, that would be great. And you also had on one of your slides applying lotion to the feet. We just want to remind people that they can apply lotion to every part of their feet, but not in between their toes, because we're trying to keep bacterial growth down. And in between the toes, the bacterial growth likes to thrive because it's warm and dark in there. So if we can keep it dry as opposed to moist, so not putting the lotion in between their toes, that's another recommendation that I would just add.
So, Bo, what are some of the mistakes that you find that people said, only to find you?
I think the main one, Dr. Kernew, is not doing that daily inspection that Matthew was talking about. I think we talk about it to people, but they really assume that if they had a problem on the bottom of their feet, they would know it, that they'd have some hint at it. And they're not, if they could just look at their feet every day, that's the number one thing at the first sign of a problem, follow up with the doctor. I can't stress that enough.
And these foot clinics and things, is that, can people access it themselves, or do they need a referral? When can people just call themselves, and how does that work?
So if you're paying for foot care services, you can usually just go online, find a phone number and call. The free services, that you need a referral. So the Feet First Foot Care, you would need a referral. And people like you guys have, I think, have the information, and most diabetes clinics have the information.
And the thing I always remember is that, really take care of your feet, wash your feet. Also, clean sock and good shoes, good walking shoes. To me, is that I sometimes skimp is that, when those soles start to wear down, replace them. And like runners do this on a regular basis. They don't use their running shoes or jogging shoes after 3 to 6 months and things of that nature. So I have lots of pairs of shoes, and my favorite shoes are usually are well worn, and they don't give the support that you need. And so think about getting good walking shoes. And
I think, Dr. Kernu, it's hard for people to assess the fit if they've got neuropathy. They can't really feel. So we used to actually do an exercise where we would get them to take their shoes off, put their feet on a piece of paper, and then trace their foot, and then put the shoe on top, and see actually that the foot is expanding in some areas beyond the shoe, the fit of the shoe. And those are the spots where they can start getting some irritation and skin breakdown.
Nice. I just want to show everybody over here is that the best beverage is still soup. So I have a soup base. I put some soup bouillon, and then I just take a bunch of vegetables over here. This happens to be spinach, and I take a handful, and it's really, you have to really put the right amount, and voila, and you're ready for soup. You can put in the microwave for a minute or two, warm it up, and you're ready to go. So that's the number one beverage for me, is vegetable soup. Let's go to the next session. Any questions from anybody? Everybody good? Anything else anybody want to say? Wonderful. Thank you so much for sharing that.
And also, I'd like to let everyone know that you can also use the chat function here. It should be on the bottom tab. If you have any questions, you can just type it in there as well.
So I'm going to be taking over next, and I'll be talking about diabetes and eye disease. So like we were talking about foot ulcers and the need to give yourself exams and screen, eye disease is another complication that can come out of diabetes. So eye screening is extremely important. So eye disease as a result of diabetes can cause blindness, and the main condition we're concerned about is diabetic retinopathy. So in North America, eye disease due to diabetes is the leading cause of preventable blindness in people between the ages of 30 to 69 years of age. So this really just highlights that this complication of diabetes is something that you can intervene in early stages and actually prevent total vision loss and blindness. So regular eye exams help diagnose diabetic retinopathy and detect eye disease early, which leads to early treatment, intervention, monitoring, and all of this can prevent vision loss. So the main thing with eye screening is that yearly eye checkups are covered for individuals with diabetes under OHIP, regardless of age. So no matter what age you are when you get diabetes, once you have diabetes, you have your yearly eye checkups covered by OHIP. So just briefly, I'm going to talk a little bit about what diabetic retinopathy is. It's a complication of diabetes that's caused by high sugar levels in the eye. So it can cause partial or total vision loss, and it usually tends to affect both eyes to the same extent at the same time. So on one hand, you have the rapid changes in blood sugar levels, which can cause sugar to leak into the lens of the eye, and this causes swelling and blurred vision. Additionally, high sugar levels in the blood can restrict blood flow, so your eye tries to compensate for this by producing new blood vessels, but these often don't work as well, and they can be leak, and they can rupture, and this can obscure vision a little bit further. So if you look at the image on the right, you can see the abnormal blood vessels starting to appear during diabetic retinopathy. So early damages can occur without pain, redness, or blurred vision. This is why it's imperative that you get your yearly eye screening done, because you might not necessarily experience the symptoms in the early stages, and that's kind of when you need to catch it in order to prevent it from degrading further. So in terms of some symptoms for diabetic retinopathy, floaters or dots, dark strings in your field of vision, dark or empty spaces in your field of vision, difficulty focusing, vision changes that seem to fluctuate, altered color vision, or if you're starting to experience partial or total loss of vision. These are the symptoms that are associated with diabetic retinopathy, but sometimes they might not come on until you're more progressed. So as for what you can expect from your eye exams are important because we want to look at the retina. Changes in the retina can indicate changes in other parts of the body. It's often an early indicator of disease occurring elsewhere. So getting those screens so that you can look at the retina is incredibly important. So you either go to an optometrist or an ophthalmologist, and they will usually take some pictures of your eyes. So there's one technique, which is fluorescent angiography. This is where they dilate your pupils and they'll take a look at the back of your eye, and that's the image on the right. The other is optical coherence tomography. So these are images of your eyes that are taken from cross sections, and they show the thickness of your retina and where fluid might leak from damaged blood vessels. So if you're thinking to yourself like, oh, did I have a proper eye screening? Was it comprehensive for diabetic retinopathy or eye disease? Just think about whether your optometrist mentioned looking at your retina, taking the pictures, dilating your pupils. In some cases, they'll actually even show you the pictures to indicate where there might be abnormalities or where they're seeing things look good. So just a couple of things to note. So I'm going to just briefly discuss some risk factors for diabetic retinopathy. So besides having diabetes, other conditions can act as comorbidities to increase your risk for eye disease due to diabetes. So one is pregnancy. So if you're pregnant and you have diabetes, diabetic retinopathy, you have a higher risk for it. So just keep that in mind. The length of time with diabetes, so how long you've had it, can also increase your risk. Poor disease management. So if you're not managing your blood sugars properly, if you're not adhering to your medications, this can also increase your risk of diabetic retinopathy. Other conditions as well. So high blood pressure, heart disease, high cholesterol. So it's important that you take your medications or implement those lifestyle changes to manage these conditions as well. Ethnicity does play a little bit of a role. So African American and Hispanic patients tend to have a higher risk. So again, another thing to keep in mind. And lastly, smoking. So smoking significantly increases your risk for diabetic retinopathy if you already have diabetes. So if you're a diabetic, consider reducing or ceasing smoking. And a few other things to note, OHIP covers eye exams every year, so one a year. That's covered by OHIP. You do not need a referral to have your eye exam. So a lot of times when we think of seeing specialists, we think of our family doctors having to provide a referral. You don't need that for an optometrist or an ophthalmologist for your eye exam that's covered by OHIP. You can contact them yourself. And usually if you've disclosed to them that you have diabetes or they find irregularities, they can communicate that directly to your physician. So either an optometrist or an ophthalmologist is qualified to perform the exam and make the diagnosis of any of the eye diseases that they're screening for. And the main difference here is just an ophthalmologist can perform procedures on your eyes, so surgical procedures, but that's just the main difference. Otherwise, both of them are qualified to perform the exam and give you your diagnosis. And like I mentioned, how do you know if you were screened? Just think back to what happened at your eye exam. And even when you go to an eye exam, making sure that during your yearly checkups, they're not just looking at whether there've been changes in your vision in terms of power, but also taking a look at the retina with those images or imaging techniques. And early diagnosis is essential to preventing vision loss, so don't skip your eye screenings.
A question for you guys and Bo is that, so for your diabetic exam, that means that you're going to have your pupils dilated. Like as you mentioned, they're not, so the doctor has to put some drops in your eyes to dilate the pupils to have a good look in the back of the eyes. And they'll also probably screen you for glaucoma too as well, to measure the pressure inside the eyes too as well. And so the key is dilating the pupils. Is that right, Bo?
Absolutely.
Great. Thank you so much.
Can I make another comment? So when people are having problems with their blood sugar, I know that you were mentioning about the eye exam for diabetes, but often there is a component of the eye exam that involves corrective lenses. So just be really careful. If the blood sugars have been high for a while, if you've newly diagnosed with diabetes, we usually suggest that you don't purchase any type of glasses because they'll probably not work for you when your blood sugar improves.
And yeah, that's a really good point.
Having diabetes also puts you at higher risk for cataracts too as well. So you really need to look after your eyes. And so, the best time to get your eye examined if you're diabetic when you make a diagnosis, because depending on the medications that we use, that can affect how we change blood sugar. For instance, we're using medications now that lower blood pressure very aggressively. And if you have a lot of changes in your eyes and we lower your blood sugar too quickly, we can actually cause blindness. So we need to know that. So really important is that, and again, as you point out, is that if you wait for symptoms, it's far advanced. And so it's like a little leak in your tire. Who cares? But when you have that flat and you blow the tire out, you're in big trouble. So don't wait to blow out your eyes until it's too far advanced. So please, please, please look at your feet. Realize that you need good eye care, and it's a great service that's available.
Oh, and I think I forgot to mention, but eye screening is something that both type 1 and type 2 diabetics need to do. So whichever type you're diagnosed with, that's something you should be looking to do. And lastly, for what you can do to reduce your risk, it's basically proper disease management. So a good acronym to remember is the ABCDEs. So A stands for A1C, your hemoglobin A1C. That's what we usually look at in your blood work at the clinic to see the 3-month average of your sugars. So if you're diabetic, you want that to be 7 or less. So that kind of indicates that you're managing your sugars all right. B is for blood pressure. So the optimal blood pressure is less than 130/80. So you want to maintain proper blood pressure control. That's something that can increase your risk of developing diabetic associated eye diseases. So maintaining proper blood pressure is also key for reducing your risk. C is cholesterol. So your LDL cholesterol, which is your lousy or your bad cholesterol, you want that to be 2 millimoles per liter or less. So that again will help reduce your risk for diabetic retinopathy. D is drugs, so drugs to protect your heart. So even if your readings are kind of baseline or borderline for blood pressure or LDL cholesterol, if you're prescribed medications for these, it's good to keep taking them and keep on that regimen because it's going to help reduce your risk for developing an eye disease complication due to diabetes. E is for exercise and eating. So this is positive lifestyle changes, just making sure you're getting regular physical activity, that you're practicing healthy eating, you're maintaining a healthy body weight. All of this can help reduce your risk. And lastly is S, which is smoking cessation. So smoking can significantly increase your risk for eye disease complications due to diabetes. So if you're a smoker with diabetes, consider cutting down significantly and if possible eventually stopping. So basically the bottom line is actively managing your disease by taking control of your blood pressure, your cholesterol, your blood sugar, and making positive lifestyle changes and essentially remembering the ABCDEs will help you reduce your risk for eye disease due to diabetes. And lastly, just a few resources where you can find some more information. So the Canadian Ophthalmological Society, Canadian Association of Optometrists, they have great guidelines on what you can expect from your appointments and what to be looking for. The CNIB, which actually has a vision loss simulator. So you can kind of use that application and see what it kind of looks like when you're developing diabetic eye disease. There's also the Angiogenesis Foundation, Diabetes Canada, the American Academy of Ophthalmology, the American Academy of Optometry, and the Government of Ontario. The two links that are here for Diabetes Canada and the Government of Ontario are actually PDF documents where they go through every aspect of diabetic eye disease and what you need to look for. So if you're ever looking for additional information, these are great resources to look to because they really break down kind of what's covered, what's expected, and what you need to do to actively manage your disease and your condition.
So you're saying, Aditi, you can actually go look at with your eyes with the changes there. What's that vision thing you mentioned there? You can actually.
Yeah, so it was a resource that was actually cited in Diabetes Canada PDF on diabetic retinopathy, and they basically kind of said that the app kind of shows you what the progression of eye disease due to diabetes does to your eyes. So if you're trying to kind of get a visual perspective on what's actually going to happen, I recommend just checking out the link. You can just Google CNIB vision loss simulator. It's the first thing that pops up on Google, and then just check it out for yourself if you're kind of curious about what these symptoms or these manifestations of eye disease might look like.
You know, I've been to a few webinars on diabetes complications for eye disease, and I hear all these, you know, these eye doctors talking, and there are so many new therapies that they can actually inject into your eyes. You know, at one time was lots of lasers, but there's so many different therapies that can protect the eye. So the first thing is that spend time to figure out where you're at and make your appointments with your eye doctor. For those who haven't had an appointment in the last year, make one. Anything else you want to add to that, Bo?
No, I think that was well said.
Perfect.
Wonderful. So I'll take over from here. We're going to talk about the different types of insulin. Initially, we're going to talk about how to use them, but the videos don't work. So I'll just point you to a little bit of resources and directions. So if you go to the next slide, just as a quick recap. So you guys remember, you know, type 1 diabetes is just, you know, your pancreatic cells stop producing insulin properly. And in type 2 diabetes is when your pancreas doesn't produce enough, or that you've sort of developed that resistance and insulin doesn't really work as well as it should. So in that case, what do we sort of do, right? Insulin is an option, you know. So insulin is sort of this hormone that's made in the pancreas, and it allows your body to use sugar, especially for energy. So one of the things is there's 5 different types of insulin. So there's short acting, rapid acting, intermediate acting, mixed, and long acting. But there's 2 main ones that you should really be worried about, and we're going to cover is that long and short acting, right? So for long acting insulin, we can sort of call it basal insulin. It delivers a constant small amount of insulin to your blood continuously throughout the day. So it sort of emulates the insulin in the body. And it's used to control blood sugar between the meals, fasting, or overnight. So currently 2 types that we know about, or we have in Canada, are Lantus and Levemir. And then rapid acting, right, it's called bolus insulin. So it's used to offset the quick sort of rapid rises in blood sugar that arise after meals. And these 2 types of insulin are used sort of together. So long acting and short acting are used in conjunction to mimic the physiological function of the pancreas. And so in type 1 diabetes patients, this alternation between long and short acting is sort of necessary because they don't have the pancreas to be able to create that. But in type 2 diabetes patients who are unable to reach their goal of blood glucose while they're taking oral medication, this is sort of when we resort to the injections of insulin. I'll open up here the floor to Dr. Kernew and Bo if they want to jump in here.
So we're going to have a whole separate discussion, and there's actually newer insulins too as well. Bo, why don't you tell us about something?
Yeah, I was just going to mention, Adam, I know this came from Diabetes Canada, but one of the things, I mean, we can hardly keep up with all the medications for diabetes because the pharmaceutical companies keep trying to improve things for us so that we can make things better for our patients. And one of the things that we've always struggled with is, even though we're talking about extended long-acting insulins, and even though it suggests on this chart that they last up to 24 hours, it always seemed that the insulin was running out by the time they were ready to take their injection again. So we knew it wasn't really lasting 24 hours. So there's a couple of new ones, Toujeo and Tresiba, that we have more evidence that they do last 24 hours. So that's a good thing. And these are really important insulins, those long-acting insulins. If you ever find that at night your blood sugar might be in target, you might have a 6.8 at night, and then you wake up in the morning and your blood sugar is 9.2, and you think, well, Dr. Kernew's not going to believe that I wasn't up in the night having a snack. And we know that that's the liver putting glucose into the blood. That's what it does overnight as you're sleeping and as your body's rejuvenating. And so these long-acting insulins are really good because you can take them at night. They can work overnight to match or counteract what the liver's doing so that you wake up in the morning with a good blood sugar. And then the fast-acting insulins, as Adam said, we don't, we use those to cover the carbohydrate at a meal. So That one little comment that I will make about those, we were actually doing a huge disservice for a long time. We were telling people, oh, they work so fast. You take them right before you eat, or you can even take them after. But we know that food works faster than insulin. So we're actually suggesting now, if you're taking NovoRapid, if you're taking Humalog, if you take a Pedra, we're suggesting that you take it 15 to 20 minutes before the meal.
And again, lots of change, and that's a whole discussion. And we often, obviously, in type 1 diabetics where you don't have insulin, you need insulin. And in type 2, the earlier parts is that you don't need insulin. Your body makes actually more insulin than you need. You're just resistant. So that's why that weight reduction putting diabetes into remission. But eventually, every type 2 diabetic, if you live long enough, you will your pancreas will wear out and you will no longer have insulin. And so insulin is a very special agent, and we'll spend more time talking about that at a later date, and it's always changing. And also too, there's different pricing of insulin and different things, so be always wary talking to your doctor is what you cannot afford, what your insurance covers, not covers. Don't be afraid to talk about cost, because diabetes care is very expensive, and there's ways around keeping the cost down. So don't be afraid to talk about cost.
Well, I'm glad Dr. Kearney brought up cost, because that's sort of the next thing I want to talk about. If you go to the next slide. So, how do we inject insulin, right? How do we administer it? There's the pen, sort of the typical way, but there's also the pump. And how do you determine what's best for you? Again, like Dr. Kearney mentioned, maybe speaking to your physician or somebody that knows more than you do about these things would be helpful, right? So with the pump, what it does is it sort of emulates the body's pancreatic cells and how it works, in that it's not constant monitoring, and it injects mostly fast-acting insulin whenever needed. But the biggest con of the pump is that it costs a lot. So it costs up to anywhere from $6,000 to $8,000. And for people with type 1 diabetes, typically need 2 to 3 vials of insulin monthly, which can really ramp up the costs quickly. And if you guys go to this link, I don't know if you can see it on the screen clearly. If you go to tinyurl.com/sugarhour, it's going to take you to a PDF from the Canadian government that sort of shows you who's covered, who isn't, and how much is covered for you, and what sort of ways you could seek to reduce the costs. And again, I'll open it up to Dr. Kearney and Bo here if they want to jump in.
So in Ontario, we're actually quite fortunate, because the Ontario government covers the cost of insulin pumps for people who have type 1 diabetes. So when Adam's talking about this thousands of dollars, it's been groundbreaking for our patients with type 1 diabetes. But if you have type 2, there's no coverage. Sometimes people have coverage at work. The other thing to keep in mind is that insulin is an over-the-counter medication in Ontario. So for some of my patients who don't have any kind of coverage, if you go and you get a prescription filled, there's always that dispensing fee. Whereas if you go to the back pharmacy counter and our people know what kind of insulin they're taking. If you go to the back pharmacy counter and you ask for your insulin, then you don't have to pay those dispensing fees. So that's one way you can save money. And there are some, there's other kind of programs for different parts of diabetes that might help to offset some of the costs.
And my advice to everybody, especially if you're the type 2 diabetics, is that you can actually prevent yourself from eating insulin by the lifestyle changes, and you can delay this. So that's why I'm encouraging, you mentioned you can have your apple juice and orange juice. Terrific. I understand that, but you're wearing out your pancreas every time you consume those. And me, I'm trying to get my pancreas to work better. Everybody in my family has diabetes. I don't. And I plead for people to really think about how to put your diabetes into remission and to really work at this. None of us are perfect, but I think we can all do a better, or most of us can do a better job, including myself. So vegetable-based soup with vegetables are the way to go. And we saw that glycemic index. So wonderful.
Yeah. All right, perfect.
Sorry, did you have anything else you wanted to add, Adam?
No, I was just about to say you could move on.
Okay. Yeah, I'll be quickly going over how to monitor blood sugar levels. And I want to start by talking about probably the most common method, or what you are most likely using at home. So with the glucometer or a capillary blood glucose test, it's the one where you prick your finger and you get a blood sample. So I have the image here on the left where you insert the test strip, you collect the sample and you get a value from your machine. And it's really easy to use. It's on the cheaper end, and I'll talk about costs on the next slide. But when you do this test, there's a couple things to keep in mind. The first that I want to talk about is that the units that you get on your lab results or your A1C, it's different from what you get on your glucometer machine. So if you look at the table on the top right, you'll see that for the A1C value of around 6.5, that actually is the same as 7.8 millimoles per liter. So it's two different units. Getting a 6.5 on your lab results does not mean that you have a 6.5 value or that you'll get the same value of what you get at home. It's a different unit, and so take a screenshot or a picture if you need, in case you need to refer back to this. Also, when we talk about values,
it's really important. Everybody should take a picture of this because I don't remember this. So again, a glycosylated hemoglobin of 6.5, which is an average blood sugar managed over 3 months, means that your average blood sugar is 7.8 millimoles per liter. And that's important to realize that. So, and so we've actually used glycosylated hemoglobin as sort of the marker for our diabetic control. And that's dependent that you have proper hemoglobin, and there's the other factors, and your kidneys work as well, which are quite reasonable as well. So sometimes you have to use both the blood sugars and the hemoglobin A1C, because it's not always reliable for everybody. And I'm not sure, Bo, when don't you believe the glycosylated hemoglobin?
Well, as you mentioned, Dr. Kernu, especially with anemia. But the other point that I'll make here, that the A1C is just a 3-month average. So it's kind of like the stock market trending. If I'm looking at trending and I want to know if I'm doing better or if I've been hitting a rough patch the last 3 months and I'm getting a little bit worse. But really the most important information is the finger pokes that you do, because you can do those at varying times throughout the day. And that's where you can follow through with what we call pattern management. What's the best sugar of the day? What's the worst sugar of the day? What can I do about my eating? What can I do about my exercise? What can the doctor do about my medication to try to improve things? It's a very targeted approach as opposed to that 3-month average.
Yeah, and also just want to quickly go over the values of what is in the normal range and what isn't for when you do this test at home. And we follow the CDA guidelines, which is on the Diabetes Canada website. So around 4 to 7 is a range before a meal, and up to 10, 2 hours after a meal. And Bo, you can correct me if I'm wrong for this one. But those are the values that you should sort of be looking out for.
Yeah, no, that's absolutely right.
And you also have those milligrams per deciliter. Those are the American units, just to put that there. So there's different units. So we're in Canada, we have something called millimoles per liter. But if you want to look at if you're your American friends, so that's why you have different units. So lots to learn.
Mm-hmm. Yeah, and so here is what I got from the Government of Ontario website. And in terms of coverage for these test strips that you have to use with the glucometer, for if you're managing your diabetes with insulin, then you get coverage for $3,000 per year. If you're managing it with just diabetes medications and you have a high risk of hypoglycemia, which means you're at risk of getting low blood glucose levels, then you get up to $400. If you're at lower risk, around $200. And if you're using lifestyle and therapy without insulin or diabetes medications, then you get up to 200 test strips per year. Okay, the next thing that I want to talk about is the Freestyle Libre machine. And for those of you who have been to my meetings before, we were fortunate enough to have someone provide free samples for us. And so I've reached out again, and we do have a few samples for you guys at the clinic. So if you're interested, please contact us there. And here I've also provided the QR code, which you can take a picture of with your phone. It'll direct you to the website. There's also a link there as well. And because of COVID, they've moved the tutorial sessions, instead of being in person, they're now provided online, and they're really great at doing that. So if you're interested, it's here for you. And for people joining in, after, because we're recording this, you can also take a picture of this as well. So this Freestyle Libre machine, this is a continuous glucose monitoring machine, and it It records both day and night, and it provides a real-time glucose result, an 8-hour historical trend, as well as a directional trend, which essentially shows you where your glucose levels are heading. So it's a really great machine, and you can connect through a phone app as well as a touchscreen reader that comes with the entire kit. And in terms of coverage, OHIP actually does cover the Libre machine for people on insulin, as long as you have a prescription from your doctor. So I think that's really great. And another last thing that I want to note is that those who have a pacemaker, unfortunately, are unable to use this machine. But then you can refer back to the more traditional glucometer.
What's the cost of that device there, Ginny?
It actually varies. So if you do have insurance, then you're normally paying just up to, I would say, maximum $40 a day. But based on my research, and Bo, you can correct me if I'm wrong, I think the machine itself, it costs around $75.
So the reader's between $50 and $75. But if people have a smartphone, they can use their phone. They don't need the reader. What's the cost is the sensor. You can see that that thing on the back of that lady's arm. She will wear that for 2 weeks, and it's $90 for 2 weeks. So for a month, it's $180.
Yeah, so it's definitely on, I would say, more on the expensive end. If you are on insulin, definitely reach out to your healthcare doctor or physician and get a prescription so that you can get that covered.
So the other interesting part about for people who have to pay for it, there are times you can actually do it for periods of time, for 2 weeks at a time. So you don't have to do it forever. So Ginny and I have done this. We've actually used a couple of those devices, and it's been kind of fun just to play with. And Bo talks about getting that instant effect there. So you can see if you exercise, what happens to your blood sugar. I was trying to improve my exercise performance by seeing how do I get my optimal glucose. None of it worked. It just needs better shape and less weight is the solution for me. And at times we'll be able to get some samples for people who are interested. So if you're interested, we can try to do that. But the cost is the cost, because each blood sugar strip is a dollar strip. You can see what you're covered for in Ontario, and sometimes additional strips. So you can mix and match in different ways to look at this. So fantastic. Thank you.
Yeah, absolutely. And before we go on to the last section where we talk about SMART goals, I'll be sending a link in the chat shortly. It's a Google form. And if you're able to fill that out at your leisure, then please do so. But in the meantime, I think, Jessica, you can get started on this one.
So really important is to fill out your SMART goals and send them into our clinic, or bring them in, because we're going to be drawing for books called 30 Days to Healthier You. So I'm encouraging you to be healthier, try some different things. So for instance, one goal may be I'm not going to have any juice for the next 30 days, for instance. I'm going to work on some other aspects of your care and things of that nature as well. So let's hear about SMART goals.
Perfect. So hi, everyone. So as Ginny and Dr. Kernu said, this last section, it's shorter and sweet. It's a little less content heavy, and we're just going to be talking about SMART goals. So you might be wondering, what is a SMART goal? And it's basically this idea where we use the letters of the word SMART to form an acronym, and each letter will basically tell us a fundamental of goal setting. So to break it down, we can see, firstly, the first letter of the word SMART, which is S, is going to reflect the need to create specific goals. So when we create specific goals, we're going to be able to identify a tangible outcome. And without this, we run the risk of it being way too vague. And when our goals are super generic, it might be difficult to center in and get the right resources to be able to accomplish that goal. So definitely we want to make it specific. It will increase our ability to achieve. Next is the letter M for the goal being measurable. So this is the idea that we should have some clear definition of success. And this is important so we can evaluate how much we've progressed and what our achievement looks like thus far. So this could be achievement in numbers. It could be measurable in a specific, let's say you had other specific goals, so long as you're able to track and see how far you've progressed since you've started. The next is A, meaning the goal should be attainable. So while you want your goal to be challenging, it should still be reasonable to achieve. And so we don't want people to get discouraged by having a super difficult goal. But of course, if your goal is also very, very easy, it's not going to challenge you enough and motivate you enough to continue working at it. So finally, we have the next letter is R for relevance. And this is the idea that we should be setting goals that are important to us. So the goal can't be something that your family wants for you or your children want for you. It needs to be something that you want for yourself. And so you should make sure that the goal is aligned with your values. And that way you're going to make sure you prioritize it and really are motivated towards it. And then lastly, we have T, meaning the goal should be time bound. And so this is the idea that every goal should have a target date that'll motivate you to work really hard to achieve your goal. And of course, a cautionary note is that although we should have timelines to motivate us to get towards our goals, we should be flexible and not too hard on ourselves. So if we don't get to meet that goal right within that timeline, it's okay. We can forgive ourselves and we'll work harder to continue and recognize that we still have made progress. That's okay, and we'll keep working till we reach that goal. So there are several different goals you can have within diabetes. This could be bettering your foot health care. And some of the options I've also listed here are things like weight loss, exercise, and dietary changes. So we'll run through what an example of this could look like. So again, the first part is making that goal specific. And so this could be something like, I will lose 15 kilograms. And having this specific goal rather than something more generic saying, I will lose weight, putting that number in your head is important because it allows you to have some kind of end goal or at least a step along the way that'll motivate you really hard to work towards that specific goal. Next, again, the idea of being measurable. So having some indication of where you are at thus far. So saying, or you can have even measures of how many times a week you want to do something. So for example, you might say, I will exercise 4 to 5 times a day. And you can track how many days a week you actually do accomplish that workout. You could also track things in a food diary, which could be super helpful. Next is the idea that the goal should be attainable, meaning it should be realistic, not too hard and not too easy. So of course, if you haven't worked out in many, many years, committing to do a 50-minute workout 5 days a week might seem a little unachievable. And even if you do it a couple of days, you might find yourself becoming discouraged. And so you might reason that a better, more achievable goal for you would be to do a 10-minute workout 3 days a week. And slowly but surely, as you continue to meet those goals, you'll increase the amount of time a day that you exercise. And you could build yourself up until that final end goal. Next, again, it should be relevant. So it should be because you want to do this for yourself, and it should align with your values. So find your real reason. So for example, I want to lose weight because I want to be off certain medications, or I want to lose weight because I want to be able to be more active with my children. Find things that mean something to you. Why do you want this? And then again, finally, the idea of it being time bound. So having dates in mind. So something like I will lose 6 kilograms by March 30th is more helpful than saying I will just lose 15 kilograms. So putting a date in mind is, of course, super helpful. And like I said, there are various goals that you could apply this model to.
Okay, so that brings us to the end of our presentation. Thank you all for joining in and listening and, working towards, bringing a healthier lifestyle in mind. And that's sort of going to be the focus of our next meeting. I've listed it here. It's always at Wednesdays at 6, but we're going to have one on March 17th as well as April 14th. And if you fill out the form, you'll notice that at the very end, I ask if you have any questions or concerns, and we'll be integrating that feedback and including any information that you are curious about in our next few presentations. So come with a list, come with your concerns, and feel free to put it in the chat or even give our clinic a call. Our clinic always has an open door for everyone, and we're more than willing to listen. So thank you all again. And I'm going to open the floor for any questions, and also if Dr. Kearney or Bo has anything to add.
Well, first of all, I want to thank everybody for these excellent presentations. Despite me, you guys are pretty close to being on time. I'm known to never, I think I've been on time twice in my lifetime. I think the day I got married, and there's been a second time, I just can't remember when that was. But saying this is that my takeaway from this is that diabetes has multiple complications. So one thing I didn't know is that when I put the cream in between my feet, I should leave in between leave the toes alone. Don't get that bacteria in there. Right now is that everybody in my family has diabetes. I don't have diabetes, and that's because I work extremely hard at preventing it. Will I get diabetes in my lifetime? Probably. But really importantly is that the question I have for Bo, for instance, a question. So you mentioned that there's all sorts of foot care, and when should I do my foot care myself if I have diabetes? When do I need professional help? What are some of the clues to say, listen, I'm over my head here?
Well, Dr. Kernu, we actually suggest that there's no harm in people going once a year to either chiropody or podiatry, because not only will they do the nail trimming and the calluses and so forth, they'll also do a little bit of education with the person. So we suggest that they go once a year. We've got those free services for people who have diabetes in Hamilton, and actually they're all across the Lynn, so they're in Niagara as well, and Brantford too. But things like not being able to bend over, not being able to see, not being able to reach your feet, maybe you're arthritic, you've got the neuropathy, so you don't really want to be bringing sharp objects towards your feet because you wouldn't know if you were going in too far or too deep. Those types of things, those are reasons to be going and getting professional care.
Now, does anybody have any questions? In one sense, it's overwhelming. On the other hand, we have a series of videos Jenny and her team put together from diabetes medications, from lifestyle changes, and in fact, after this meeting, I have to go to the what I call the 3 M's: meditation, mindfulness, and movement. So I'm going to be walking the stairs in about 10-15 minutes, and encourage you to find some way to do it differently. One thing I'm going to encourage people as well is that you can email us at drkernu@232gmail.com. If you want one of our crew to give you a buzz or a call or a phone call, we'll do that, because these young people have motivated me. If it wasn't for them, I would not have tried things like intermittent fasting. I wouldn't have actually climbing the stairs on such a regular basis. One reason I climb the stairs is that they want to go faster than me. Well, right now, some of them can, some of them can't. I want to still keep working for as long as I can. And so if you want one of these young people to call you up to help guide you, motivate you, they'll be a good health coach and a good resource to yourself. If you need to see, we're lucky, we're blessed with 2 really expert diabetic educators. Here's Bo and Dragana, and they're in our clinic once a month or so. So if you need extra support and help, we'll get you there. I think everybody should have a blood pressure machine. Everybody should have a scale. Everybody should start every meal with 2 glasses of water. Everybody needs to look at their feet every day. Everybody needs to go for their eye exam yearly. And if you have any questions, don't be afraid to ask. Don't wait until it's too late. I'll never forget is that I had this leak in my tire, and I didn't worry about it, and I blew the tire. And blowing a tire, you can replace the tire, but you can't replace your eyes, and you can't replace a foot, and you can't replace a kidney. So these are things you can all do differently. Any thoughts from anybody else? Jenny and your team, I'm going to give you guys the last word, and I'll get Bo. Any final comments yourself, Bo?
No, I think I would just echo your comments, Dr. Kernu, and then I would also say, be kind to yourself, because as it was said at the last little part with the SMART goals, you're going to not always succeed the first time around. So be kind to yourself. Absolutely.
So to me is that don't be afraid to make mistakes. But don't get on your case. I mean, life's tough enough. This is time to enjoy experimenting. And one of the things I find frustrating is that not trying is the wrong thing. So try and have fun doing it. I'm having lots of fun. I never thought we'd be doing a Zoom meeting on a Wednesday night, and I thank you all for joining us. I never thought we'd be in this pandemic. I never thought I'd still be wearing a mask in my office over here but you know what? I learned so many new things, and we're sharing, and please don't be hard to yourself, but please make an effort to try something different. Ginny, any final thoughts? Anybody else from the team there?
Yeah, I agree with everything that's been said. And yeah, be kind to yourself. And also, it's not going to be easy. You're going to have to actively work towards it. So make those SMART goals, put it up somewhere on your fridge, beside your door where you're seeing it and you're constantly reminding yourself that this is something that you want to do. You want to start putting your health first, and it's not too late to start working on this. And the entire clinic is here to help you. The volunteers, Bo, and as well as Dr. Kernew.
Well, I want to thank everybody for attending and for your patience. And I wish everybody a great day. Keep working at it. And don't forget is that most of the things that we learn are forgotten. So that's why this is recorded. This is for you to come back at any point in time. I love all these resources and things. And I thank you all for your hard work, and we'll move forward. I look forward to seeing everybody on March the 17th, April the 14th. See, I can't remember. I have to look at my notes all the time. And I can remember a clinical trial, but I can't remember what day of the week it is. And there you go. So I want to wish everybody a good night. And we'll see you soon. And again, send in those forms. We're going to give you guys a call just to check up on you, to see how you're doing and see how we can support in any way. So we have this diabetic team that just gives you calls from time to time just to say hello. It's sort of like a blood sugar. You can do it when you want to. We're going to hopefully give you a call and try to make things a little bit easier for you. I want to thank Ginny, Bo, and her team for everything. I learned a lot tonight, like always. I'm a heart doctor, and now I'm learning more about diabetes, and that's something I didn't think I was going to do. But it's okay. I'm glad to, because they're all interconnected, and we're all working together. So good night, everybody.